All right, this is Josh Halls for a FNP 597 clinical residency. October, what is it, October 7th? Jeez. This clinical site was just at a family practice in Orem, Utah. A brief description of the case is a patient came in with just some discomfort, chest pain. She was born with a murmur, but was believed that the murmur had resolved. She's a 26-year-old female of Caucasian descent, not married, has good insurance, is a reliable historian, but is just having chest pain. It's not so bad that she needs to go to the ER. It's not radiating down her arm, but it's discomfort enough to where she's noticing it. There's no rhyme or reason to why it's coming. She said it just happens sometimes and it resolves. I liked this case because it was something I haven't seen before. Murmurs, you don't really come across. I mean, I know they're apparent in pediatrics, and most of the time they resolve. So you don't hear a lot as they get older. And a lot of times when they're grade 1, grade 2, they don't cause a lot of symptoms. So to have one that was causing a little chest pain, because the patient was on omeprazole, it just was really interesting to me. I really enjoyed it. To hear a murmur, it's pretty cool. All right. So client's initials BR, age 26, Caucasian female, date of birth in 1996, 1/1/96. Chief complaint is I'm having chest pain. Again, patient was born with a heart murmur and it hasn't bothered her since she was young. Pain in the chest recently on and off, nothing with patterns to it. The onset is random, no set time or due to anything like exercise or eating. The omeprazole helped at first a little bit. So I would imagine the patient was coming in just to change that medication. The locations in the chest, duration, again, only lasts for a few seconds and then it'll go away, but it is very sporadic. Characteristics, it's just a dull ache in the chest. She states there isn't anything that aggravates it. She just notices it every now and then. She also notices that there's nothing that really relieves it. Although, again, the omeprazole helped a little bit when she first got diagnosed with gastroesophageal reflux disease. Again, severity, there's no pain radiating down the arm. There's nothing that would lead us to believe that it is something that required emergent care. Past medical history, patient did just recently finish off a metronidazole for bacterial vaginosis. She got mild acid reflux and she had a scalp laceration in the past. No allergies to medications or seasonal allergies. Again, medications, the only medication she's taking right now is omeprazole. Family history, patient was kind of unsure of her family history. She just knows that there isn't really any cardiovascular history, no heart attacks, no severe cardiovascular disease. She currently lives with her roommates and is going to college. She has never tried tobacco or alcohol or illicit drugs. She does try to exercise 5 days a week, so relatively healthy. She eats pretty healthy as well. Denies any sexual activity. Her surgical history is unremarkable. She claims that she is up to date with her immunizations. Review of systems, everything except for the chest pain was unremarkable. She wasn't having fevers or chills, no double vision or loss of vision. Again, cardiovascular chest pain, not with shortness of breath. There was no edema in the legs. Nothing that would lead us to believe that there was some sort of heart failure or anything else that could possibly be causing that shortness of breath, so no lung issues. Skin was all no lesions. Her vital signs. Heart rate was at 73. Her temp was 36.4. Blood pressure was 110/62. Heart rate or respirations was 16, 99% on room air. Pain. She just mentioned that when it's happening, it's just like a 2 or 3 out of 10. Her height, 172 centimeters, 73 kilograms for a BMI of 24.6. Labs. So we sent this patient to a referral for cardiologist, but what we wanted to have done was all the labs we thought the cardiologist would ask for, we wanted to have them done before she got there. so that when she went in, it wasn't just one of those appointments where you say, hey, welcome to cardiology, we need these labs done. Come back when they're done. So we sent her for a 12-lead EKG that day, wanted that troponin and an echocardiogram. Physical exam, there's, again, no apparent stress, no fever, chills, unexpected weight loss. Pupils were equal, round, and reactive. Chest was, upon respirations, it was bilaterally symmetrical. No rhonchi, wheezes, or congestion. Cardiovascular rate was regular, other than there was this grade 1, maybe 2 murmur. When the studies that I read, after I did this, state that most grade 1s, they're heard by cardiologists, not really by a regular clinician. But it was pretty low, it was pretty soft, so it could have been a grade 1. And it was found on the left side of the sternum, second intercostal muscle, which coincides with aortic murmurs. Abdomen was soft, non-tender, we had her breathe in, and no gallbladder, appendix pain that could have been radiating up to the chest. Patient denies any trouble with urination, no longer having bacterial vaginosis. Psychiatric was pleasant, interactive, and appropriate for her age. She wasn't feeling depressed or anything. No anxiety, so that kind of ruled out any anxiety attack, feeling, impending doom with the chest. So our assessment was a differential of a heart murmur, grade 2, possibly grade 1, gastroesophageal reflux disease, and then possible aortic stenosis, something that could be causing pain. Interestingly enough, the EKG came back abnormal. So it was a good thing that we sent her to, I didn't get to see, my clinical instructor just told me that it did come back abnormal. So we sent the patient with a murmur. It was clearly out of our scope of practice. We sent her to a cardiologist. We sent her to get the labs done. We chose this therapy because it's just out of our scope of practice as regular clinicians. The patient was very acceptable of the plan of care. Going along with Gene Watson's theory, nursing theory is truly, if you get down to the basics of it, is caring for patients. And so we believe we were consistent with that, caring for her as a patient, knowing that, hey, we're not going to try to do too much here because it is a murmur, just maybe up her omeprazole, well, that's a max omeprazole, but maybe switching to a different for GERD, or even possibly giving an anti-anxiety med, even though she wasn't having any anxious or anxiety type feelings. So again, there were tons of studies that mentioned that an echocardiogram is the number one thing that needs to be done with someone with a murmur because it's testing that blood flow. So we sent her for an echocardiogram, 12-lead EKG, and a troponin level just to rule out that, the heart wasn't having some breakdown in the tissue. Every one of those studies mentioned that an echocardiogram was the first thing that they did with patients with murmurs. There wasn't really any alternative considered with the murmur. We just knew we were kind of out of our scope. So again, caring for this patient, we wanted to make sure we sent her to the right place with all of the correct, all of the correct labs already done, so she didn't have to go back. That's one of the things that can be the hardest thing for a patient, is having to go back, getting 2 visits when it could have just been 1. So I think that was something that we did very well from a clinician standpoint for this patient.